Next on Primary Care, we're on the road at Second Ebenezer Church in Detroit to talk to Dr. Garen Wolff about asthma.
The American Association for Allergy and Foundation stated that Detroit was the most challenging city to be in if you have asthma, which is remarkable.
Hello, I'm Dr. Lonnie and welcome to Primary Care, the show dedicated to improving the health of African Americans. Asthma is a chronic lung condition that can affect people of all ages, sexes, and ethnic backgrounds. But for African Americans, the rates of hospitalization and death from asthma are higher. Compared to white Americans, African Americans have a 40% higher risk of developing asthma and are 5 times more likely to visit the emergency room and 3 times more likely to die from asthma. These are alarming statistics that my guest today encounters on a daily basis. We're happy to be joined by Dr. Garen Wolff. Dr. Wolff is a board-certified allergist-immunologist. In fact, she is the only allergist and immunologist in private practice in Detroit. She is a proud native of Detroit who has a passion for the city and for treating asthma. Dr. Wolff, welcome to the show. So glad to have you.
Thank you.
Thank you for joining us. Why haven't we gotten better control over this disease that's been around for ages and probably has affected somebody that we know or in our families? We're just not doing a good job.
Yes, so with asthma, particularly in the city of Detroit, Detroit has a lot of glaring issues that result in such a high asthma burden for African Americans and just people in general. In Detroit and specifically, there's pollution. So we have a 61% higher chance of living in a county that has unhealthy air. So the question is, where does that come from? Where does this pollution come from? Well, there are 2 sources. So the Harvard Medical School review found that there are 2 zip codes in Southwest Detroit, and in those zip codes, there are over 150 facilities that emit toxic fumes.
Producing the stuff.
Exactly.
Yes.
And so that includes refineries such as the Marathon Petroleum Refinery, there's the U.S. Steel plant, and so that's one source. The second source are the mobile sources. Detroit is the motor city. So we have cars, we have trucks, we have trains, and all of that emits diesel fuel. But the most important part is the proximity of the industrial sources and the mobile sources to our homes, to our schools and our playgrounds. And that significantly influences asthma attacks and asthma statistics in general.
You know, going back maybe about 15 years now, we got involved with the Detroit public school system and just looking at kids in elementary schools, and we found that our asthma control rate was single digits, simply because of all of the reasons that a community like this suffers from lack of access, et cetera. So, I mean, we know that the reasons, they're old and we can keep repeating them, but single digit failure rate for asthma control in elementary school age children, which we thought was just deplorable. If we do it to our kids or allow it to happen to our kids, we'll let it happen to anybody. What can be done at this point from a healthcare delivery standpoint of view to improve these rates?
So from an allergist-immunologist, perspective, there are a couple ways. First, community. So a lot of community organizations, churches, they can provide health fairs in order to connect the community to physicians. That's number one. Number two, a lot of these organizations can also have health and wellness committees that can highlight diseases that are prominent in people of color, diabetes, hypertension, asthma, which is what I see. And third, we can make sure that patients are aware that the allergist actually exists. And besides the education through these community fairs, we can also make sure the schools who see these children have a school nurse. And if they don't have a school nurse, then they have some type of connection with a clinic or a hospital to be able to help, particularly the children with asthma.
Right. Growing up in Detroit and being a product of the Detroit public schools, we always had that availability. That has been eliminated, though.
Yes.
We need to get back in front of these folks to talk about how we reconnect those kinds of things, because this disease is not going to improve on its own. It's going to be here. We're going to see it. I'm a pulmonologist, and I've grown over the years to think and to believe that all asthma that is not treated properly turns into an element of obstructive lung disease in an adult, simply because we didn't do what was right when you were 12. Okay, now you're 42 and you've got an issue. That's been my experience.
Very much so. You know, the whole mechanism of asthma is reversible. Asthma has a reversibility component, which is why we use those inhalers. However, when your access to physicians, to healthcare is interrupted, your asthma is not treated. And as you said, the lungs start to remodel, they start to change.
Exactly.
And instead of being compliant, meaning being flexible, being able to reverse, you start getting these lungs that become restricted. And so now we have asthma, as you mentioned, that moves towards a COPD picture. And with African Americans in particular, because we seek our care more in the ERs, in the the emergency rooms or the hospitals, our asthma, our lungs are getting worse. And so when we finally present, now we have these lungs that aren't going to be as flexible as we would like them to be. And now it's harder to treat. Now you're defined as difficult to treat asthma.
So how should primary care physicians work with specialists like yourself? I mean, they're challenged already with all the things that they have to do throughout the course of a day. At what point in seeing that asthmatic patient should they be saying, I want you to see Dr. Wolff?
Yeah. If a patient has allergies and asthma, definitely send them to an allergist-immunologist, because there is a chance that those allergies are contributing to that asthma. And we want to, again, minimize any trigger that's possible. If you have a patient that is on a controller medication, that's on like Symbicort or Dulera, I would also send them over to an allergist-immunologist too, just to make sure that their asthma is being completely optimized. There's the asthma control test, which is a nationally referenced test that we give to patients. If their score is 19, 19 or below, then you should definitely refer them to an allergist.
Basically, the primary care physician needs to be on the lookout,
Yes.
so to speak, in
Yes.
terms of what these things are. How can we actually identify the disease state in children and adults? What steps should primary care physicians be taking to say, I think you have asthma?
You know, children, it's very interesting because we categorize asthma symptoms with adults and adolescents, and then we look at children who are 5 years and younger a little bit differently. When we look at adults and adolescents, there are four big symptoms. There's cough, and most of the time that cough is worse at night. There's wheezing, which is that whistling noise. There's chest pain or chest tightness, and then there's shortness of breath, inability to catch your breath. Those four we always see, with asthma. With children, wheezing is very big. Children 5 years or younger. And so with wheezing specifically, if they have a cold and they wheeze for greater than 10 days, take a look at that. If they have wheezing episodes outside of a cold more than 3 times, take a look at that too. And then if they have that family history of asthma or allergies, or if they themselves have eczema or allergies, then it puts them in a category of most likely being diagnosed with asthma. One thing about being diagnosed with asthma is that we use breathing tests. 5-year-olds, children who are 5 or younger, they can't blow into a tube on demand all the time. And so we have to look at those clinical symptoms in order to diagnose them. And wheezing is a very, very big factor. If they're playing on the playground, they start to wheeze. If they start laughing and they start to wheeze, or they having shortness of breath, there may be some asthma there.
We just come out of still in the pandemic.
Yes.
Okay, it's not over. We're going to be dealing with this for a while in various forms, but from a lung standpoint of view or an asthma standpoint of view, what has been your experience in seeing patients who are on this side of the pandemic who may have had COVID?
Yeah, so that's a great question, because when the pandemic started, it was all respiratory diseases. The thought was all respiratory diseases would lead to death. Well, research has found that patients with asthma, if they acquire COVID, they do not have a higher risk of death than those who do not have asthma. But that does not mean that COVID is harmless. So what I've seen, so I've had patients that had very minimal asthma, minimal symptoms, if any at all, barely use an albuterol inhaler. They get COVID, and now their intermittent or mild asthma is now moderate asthma. So now they have to use an asthma inhaler every day as opposed to just as needed. And the duration of that is really unknown. I have some patients that contracted COVID a year ago, and they are still requiring an inhaler more than they did before. And then I have others just during a short period of time. So it really varies. But the good news is that the mortality rate for patients who have asthma with COVID is very, very low. Now, we talk about the asthmatics who unfortunately have not been able to see a healthcare provider. Now their lungs are not as flexible. Their lungs now look like a COPD lung. COPD patients have a higher mortality of death with COVID. But if your asthma is not treated, you can get to that point and now you have a higher mortality.
And thus this diagnosis of long COVID.
Yes.
Which a lot of people are falling into that category simply because, as you say, shifting their category of classification, mild to now moderate, or I have patients who are walking around on oxygen 24/7 afterwards who had no evidence of hypoxia or desaturation prior to getting COVID. Here again, we're kind of learning a lot of these aspects as we go, but it's interesting to note that it started off being a disease that primarily we thought was only going to affect the lungs, and this extension of this disease that we're seeing for months now into years requires continued treatment. So we're back to the pediatric population again. Kids who got COVID probably are even at a higher risk of now all of a sudden you have issues that you didn't have before that require attention, which is more reason for them to have the ability to connect with and to have the availability of treatment from healthcare providers. Talk about treatment of this disease.
Yeah, so with treatment for asthma, the most important is maintaining symptom control and making sure that patients do not experience asthma attacks. And that really is based on a partnership between the physician and the patient. We want to make sure the patient understands their disease, number one. So many patients say, well, could this be cured? Can I be cured of your asthma? You can't be cured of asthma, but we can manage it well enough that your symptoms can be very minimal. And when we say management, we just don't mean medication. We mean other asthma triggers, indoor allergens, dust mites, cockroach, which has been found to be a significant mortality, causes mortality in patients with asthma. So if we minimize all those things, smoking, we can really better manage asthma.
So medications.
Yes. So for the medications, the gold standard is an inhaled corticosteroid, which is an inhaler that has some steroid in it. And that is the gold standard for both adults and adolescents when we treat asthma. Why? Because asthma lungs are always inflamed. They're kind of angry and they're very, very hyper-responsive. That steroid brings down that inflammation. And that steroid we use as a controller, meaning you use it every single day. Or if you have the very mild asthma, you use it as needed. We've kind of lost favor of the albuterol as the mainstay asthma treatment. We use more of the inhaled corticosteroid. Now, if you have a child less than 5 years or younger, you still use the inhaled corticosteroid, but you can also use a tablet. It's called Montelukast. The other name for that is Singulair, and that also helps manage asthma. I would like to say Singulair has a black box warning on it. So if there's anyone that has an underlying mental health concerns, we just want to make sure. So whenever I prescribe Montelukast for an adult or child, I always make sure to tell them, if you experience any mood changes, take it off. Call me.
Yeah, that approach needs to be broadcast, because I find that in the primary care world, we just have not adhered to that approach well enough to help patients avoid a lot of these things, especially when it comes to the triggers of asthma. When I was a fellow, we used to do building checks, and we found that they would label certain buildings, especially in some of the school systems around here. Oh, this is a sick building because it had asbestos and a bunch of other stuff floating around. But we never got to the point of comparing whether or not there was an increase in certain disease states in the student population because of that. But here again, we know that there are triggers to do this, especially in the homes. You know, why do you have that old-fashioned shag carpet still on the floor? That sort of thing, okay?
Exactly.
And we never, you know, people are so busy, we haven't gotten back to that old-fashioned approach to sit down and say, or have someone in the office, an educator, the physician, someone start talking about those kinds of things in the home, what kind of heating system you have. I mean, the list can be exhaustive sometimes, but still it's necessary. I've always been surprised at what you find, that what comes out when you take the time to ask those kinds of questions of patients. Here again, Detroit represents a particular situation for us.
Yes.
The nation has a similar situation. Nobody's passing, you know, the kind of numbers we're putting up. We don't have passing grades in this. Do you see anything that can be done from a community-wide standpoint of view? We're here at Second Ebenezer Church in Detroit. The church we know plays a role in a lot of these things, especially when it comes to getting an audience. Our community organizations, which you're involved in, of course, play a role in this. What role does the community play in terms of educating, in particular on the disease like asthma? Because sometimes a lot of us is sitting in the pews on Sunday.
Well, first, I tell patients, because it seems as though when I see patients, they always know someone else that has allergies
Yes.
or asthma. Everybody says, my cousin does. I said, well, do you ask them, do they see a physician? Are they seeing someone for their breathing problems? That's number one. So if you are in the pew and you see someone coughing, at the end of the service, you could ask them, I hear you coughing.
Sure.
Do you see a physician, or are you aware of seeing someone, to deal with that issue? In Detroit in particular, we have it's called a housing repair crisis. University of Michigan did a study last year that showed that 13% of Detroiters live in a housing hazard. What does that mean? So pipes, roof, bad plumbing, leaky roofs lead to development of mold. We have the old carpets that harbor the dust mites and the cockroach or the animal dander. So what can we do as a community? One thing is dust mite covers. There are other states that have organizations that provide dust mite covers to people, because dust mites are a big trigger for asthma. So dust mite covers, along with spacers or inhalers that actually some of the national, like the American Lung Association, can actually give to churches, yes, to help them with managing asthma.
Very good. We're up against a break. Dr. Wolff, we're going to take a short break and we'll be right back with more of Primary Care.
You know, the church is a repository of truth, not only of inspirational truth, but informational truth. All of the vital things that are important for our health ought to be a part of what the church helps to disseminate on a regular basis. With its captive audience from week to week, then everyone should know all about diabetes, all about hypertension, all about many of the other things that come and afflict us as a people. These are the things that are so important for the church to recognize, because an informed people are a healthy people.
Welcome back. We're here with allergist and immunologist, Dr. Garen Wolff. Dr. Wolff, a lot of people think that there may be a hereditary component to this disease. We get that question like you do a lot, because my brother had it when we
Yes.
were kids and stuff. I mean, talk about how the association of asthma fits in with that.
So asthma is not a genetic condition. There is not a mutation in a gene that leads to asthma. It's not like sickle cell or Huntington's disease. So in our world, kind of in the allergy world, asthma is defined as a multifactorial disorder, meaning there's so many factors that contribute to its development. In our world, we have a term called the atopic march. Atopic stands for allergic diseases, and MARCH stands for progression. So the atopic march starts in childhood. So first it starts with eczema, the other word for that is atopic dermatitis. Then it moves towards allergies, usually peanut and cow's milk. Then it moves towards allergic rhinitis, also referred to as hay fever or allergy of the nose, and then it settles on asthma. So if you have a child and you have asthma, there's a high chance that your child's going to have asthma. If you have asthma and eczema, then there's a high chance that your child will have those too. And so that's what we commonly see. And then when you add that family familiarity component, plus they live in an apartment, they have an old carpet, they may have some
the triggers,
mold.
yeah.
Oh goodness, they're right next to the Marathon Petroleum Refinery. You've got asthma. So that's why we look at asthma more as multifactorial with a lot of things that can contribute to it.
So tell the listening audience or the viewing audience what a allergist-immunologist really is.
Yeah, many people don't know I actually exist. There are only about 3,100 allergist-immunologists in the country. So an allergist-immunologist is commonly referred to as an allergist, and we are specially trained to diagnose, treat, and manage asthma, allergies, and immunologic disorders, which is a big word for problems with the immune system. And some of the diseases we treat are very common. Some are exceptionally rare. I treat all ages, so from babies all the way up. And then allergies and asthma and disorders of the immune system, they affect all organ systems. Allergies affect the eyes, they affect the nose. Their hives is also part of allergy that affects the skin. So there's a very wide range.
Everybody, or a lot of people, not everybody, a lot of people have pets that
Yes.
they just will not give up.
Will not give up.
I mean, I know that can be a nightmare for
Yes.
an office like yours that says, I'm going to keep the cat. And I don't know what
Oh,
they're
yeah.
going to say. Yeah. But here again, talk to us about how having pets in the home can affect an asthmatic patient.
Yes. So I saw a little girl who had an allergy. She had horrible allergies with asthma. And every time she got next to the dog, she would have an asthma flare to the point in which she was going to the ER multiple times. And the family did not want to let go of that dog. She had a dog and a cat, and both of them were triggering her. So we have options. The best option is removing the pet from the home. That's out. Nobody wants to do that because it's their family member and it's devastating. Okay. So what I say to them is keep the pet outside the bedroom. Okay. Clean all of the linen or any surface that the dog touches. That's number one. Also, we have allergy shots, okay? So allergy shots are a process in which we actually inject you with things that you're allergic to, and that really brings your immune system down so you won't react. So that's another option. Or we just make sure that you are on your Zyrtec and your Flonase spray. So I understand people's love for pets, and in medicine, we look toward more of shared decision making. We both come to a decision as to what works best for the patient instead of telling them kind of what to do.
Because they are resistant. Yeah.
They're very resistant. And when you have a little girl who loves her dog, it's hard to say no. But we have to look for her well-being too.
That's true. You know, we've got new drugs,
Yes.
okay, out there that treat particular things, especially immune system type processes. Where are we going with this in the future? I mean, what's the role of those drugs now, especially the ones that talk about the treatment of asthma with elevated IgE levels?
Yeah.
I mean, where are we headed with that in terms of patient acceptance, first of all, because you know, you gotta get them to buy into what they see on TV in terms of prescribing. At the same time, they do have a place and they do have a role.
Yeah. So asthma research has come a long way when it comes to treating asthma in particular, because there's so many different types of asthma that are out there. And so there's a medication called biologics. And these medications are antibodies that target certain cells that are involved with asthma. And so in 2003, the FDA approved the first biologic medication. It's called omalizumab. Try to say that multiple times.
Right.
The brand name is Xolair, and that was approved to treat adults and adolescents that have severe asthma.
Right.
From 2003 on, Xolair or omalizumab was found to be great for patients with hives and patients with nasal polyps. So there have been numerous biologics that have come after that time. Early this year, a new biologic called tezepelumab, the brand name is Tezspire, came out. And why is that so unique? Because that biologic can be used for any type of asthma. So there are some people with asthma that have allergic asthma, means their asthma is triggered by grass, trees, weeds, etc. But there are other people that have non-allergic asthma. And so this drug can be used for either of those two patients. And that's groundbreaking because that's the first time this drug has ever been offered. Now, this drug you have to inject yourself every 4 weeks. When you tell patients that they have to inject themselves with a medication, they don't like that. But they also don't like going to the emergency room every single week, being on steroids. And we know steroids have horrible side effects. If you're a diabetic, it increases your sugar, increases your blood pressure, and it makes you just
bounce off the wall.
Bounce off the wall, exactly. So they would rather use a biologic medication, which is an injection they can do in their home every 4 weeks, than have to face with the emergency room. But that's why it's important that we have to explain to patients the importance of medications and listen to how they feel about or their reservations about medications.
It's very interesting that you mentioned explaining this to patients, because this is, in a lot of disease states, we really have not taken the time to do that. We really have not provided the education process, or someone who's a better teacher than I am in the office to do it. And that becomes so important. Asthma may be the prototype of that, because self-help is very important. And what they do once they leave the office is so important. So we can easily turn the tide on this a little bit by providing that. I mean, the educated patient is going to be a better responsive patient anyway. So where am I going with this? Providers have to step up. Education of the community is fine. It has a necessary piece. Education of the providers is something that we need to focus on. Admit that we are lacking and step it up a notch in terms of what we do, especially in the primary care arena. That is so vitally important. I've seen people who were told that you're going to grow out of this, which is a common phrase that people have picked up on, which is not necessarily true at all, especially when your symptoms are continuing. You have an issue.
It's a chronic disease.
It's a very chronic, very much so, very much so. Dr. Wolff, it has been a pleasure having you with us today. Thank you so much. It's certainly enlightening. One of our better interviews, I must say, that we've had on a disease state that hits close to home. I lost a daughter to asthma 10 years ago. And
I'm sorry to hear that.
it still stings throughout our family. So it's something that really strikes close to home. Thank you so much for coming and being our guest on Primary Care.
Thank you very much.
Good. Our guest has been allergist and immunologist, Dr. Garen Wolff. Seeing an asthma specialist like Dr. Wolff and getting involved in community asthma education programs will help in the fight to prevent and better manage asthma. For Primary Care, I'm Dr. Lonnie Joe.